session at the end of the webinar. So if you get any queries in between the session, just drop them on our comment section. We will get back to you later on. Today, as a speaking delegate, we have with us a very special guest, Dr. Christine Weil Sindt, all the way from USA, and she will be talking about eyelid or Meibomian gland evaluation. Before she begins, I would like to give her general introduction. Dr. Christine is an OD fellow in the American Academy of Optometry, and she has done her subspecialty in advanced contact lens fitting. And also, she is a professor of clinical ophthalmology and director of the contact lens service in University of Iowa Department of Ophthalmology and Vision Science. Also, she is the president and co-founder of the Scleral Lens Education Society and designer and founder of the iPrint prosthetic custom impression scleral lens technology. I again welcome you, Dr. Christine, on behalf of Mero Eye Foundation and all our participants for today's session.
Thank you. Well, I am so pleased to be back in Nepal again in just a couple weeks here. So I would love to talk to you today about Meibomian gland evaluation. This is probably the most simple thing I do that has the biggest impact on my patients in my practice. So just by way of disclosure, I don't have any significant disclosures for this particular topic. So what we're going to talk about today are the Meibomian glands. And these glands are really important for the comfort, the functionality of the ocular surface, the functionality of vision, and if you wear contact lenses, certainly how those contact lenses fit. We're going to talk today about definitions to make sure we're all talking about the same thing. We're going to talk about structure, anatomy, dysfunction, and then of course, how we in our practice affect our patients to get them moving, working appropriately. Okay, so we're going to talk about the language of Meibomian gland dysfunction, the structures, and then the techniques. So let's first talk about the meibum. The meibum are the oils and the secretions that are secreted from the Meibomian glands, and they're extremely complex. Everybody's meibum is a unique signature to that individual person. So nobody has the same exact composition of meibum in their tears. And the meibum is that top layer of the tear film that prevents evaporation off the surface of the tears, off the ocular surface. Now, the composition of the meibum will affect things like your contact lenses, because different types of waxes and esters and fatty acids and cholesterols will stick to the surface of the contact lens and can create a non-wetting situation on the eye. Now, the meibum has many, many purposes. One is it provides a smooth optical surface. You know, in my clinic, we talk about the cornea specialists versus the tear film specialists. The cornea specialists say the cornea is the most important refractive surface of the eye, and the tear specialists say the cornea is just there to hold up the tears. So, but the meibum is what keeps those tears to the surface, and it creates that air-lipid interface. It reduces how much the tears evaporate off the eye. It increases the stability or the structure of the tear film. When we blink, okay, it increases the spreading of the tears across the eye. Like if you were to oil the track of a door, it would smooth, glide more easily. It actually prevents the tears from spilling over onto the face. People that don't have enough meibum in their tears or oil in their tears will actually spill over onto their eyes. It prevents contamination of the tear film by other oils, bacteria, and things that are on our skin. And when we sleep, it's the meibum that seals the eyelids together so that we don't have increased evaporation while we sleep. And of course, if you have a dysfunction in the meibum, you have a dysfunction in all of these properties on the surface of the eye. So let's talk about the anatomy of the meibum. Now, the The Meibomian gland is this back gland right at the back of the eyelid here. And it's surrounded by this little muscle called the muscle of Ryland. And every time we blink or squeeze our eye, this muscle contracts and forces meibum out into the tear film. We have other little glands, the glands of Mole and Zeiss, which are right here in the hair follicles, but those are like sweat glands. They certainly can become infected and have problems. But today we're going to talk about this gland here, the big Meibomian gland. Now, we do need to talk about the structural or anatomical features of the eye so that as we move forward, we are using the same language. So when you look at the surface of the eye or the eyelid margin here, several structures we need to find. We have the eyelashes or the anterior part of the eyelid, but this little line right behind the eyelashes and in front of the Meibomian gland orifices, there's this little gray line, and that's actually the muscle of Ryland that you can see on the surface of the eyelid margin. This gray line is the anatomical divide between the anterior and the posterior lid margin. Then we have the Meibomian gland orifices, and then we have this sharp mucocutaneous junction. So everything anterior to the mucocutaneous junction is skin. Everything posterior to that is a mucous membrane. Now, the Meibomian glands are situated within the eyelid. We have more of them in the upper eyelid than we have in the lower eyelid. And the upper eyelid, they're much longer and thinner, and the lower eyelid, they're much shorter and fatter. Now, we don't really know which eyelid contributes more to the tear film. There's a thought that you need about a third of your Meibomian glands functioning at any given time in order to have a stable meibum on the ocular surface. So not all the glands are necessarily functioning all the time, but you do need at least a third of them in order to have a healthy tear film. Now, each gland consists of these little acini, which are these little round, they look like little clusters of grapes on a stalk. And those are the little acini. Now, acini are what are called a holocrine cell. That means that it's actually, each acini contains an entire cell with an entire cell membrane and a nucleus within that cell. Now, what happens is that nucleus degrades and the whole cell shrinks a little bit and gets pushed out into the ductal, which is the center duct of the Meibomian gland. So that's called a holocrine secretion. So the meibum is actually a packet of oil that gets pushed out onto the ocular surface. Now, anterior blepharitis. When we refer to anterior blepharitis, what we are talking about is anything anterior to this gray line. So there's that gray line right there. And anterior blepharitis is anything that's anterior to that. This would include things like Demodex, but it could also be things like allergy. It could be lid disease. There's many things that are anterior blepharitis. Typically, we refer to that when we talk about lid scurf or debris on the anterior surface of the eye. When we're talking about Meibomian gland dysfunction, we are talking about posterior blepharitis. So there's that gray line right here. And so we are talking about things that are behind or closer to the globe for posterior blepharitis. Posterior blepharitis, though, could also include allergic reactions, acne rosacea, ocular rosacea, and infection as well. Now, when we refer to the term Meibomian gland dysfunction, what we are saying is that there's either we don't have secretions onto the surface of the eye, or that the secretions that are being secreted, the meibum being secreted, is unhealthy and does not contain the proper mix of oils and esters and things that will stabilize that ocular surface. So that's what Meibomian gland dysfunction is. And what happens with that is you get the altered tear film, and eventually that will lead to ocular irritation because the tear film's not performing correctly. That will lead to inflammation, and eventually the surface of the eye itself will become diseased and have untoward effects. Now, the most common theory that we have of how meibomian gland dysfunction happens, or how these glands atrophy over time, is that in a normally functioning gland, you have the acini and you have the central ductal. So you see here in figure A, the gland, these holocrine cells secrete into that central ductal. The muscle of Ryland contracts and squeezes, and it pushes that meibum onto the surface of the eye. If the ductal becomes clogged, either with an inflammatory process or with keratin that forms over the surface of the orifice, the ductal there, what happens is the meibum cannot escape out the ductal, and it's actually forced back. The pressure when you squeeze is actually forced back into the acini. The whole ductal kind of swells up to its capacity, and over time that chronic stress will actually cause those ductals to atrophy and to decay. And that's how we get meibomian gland loss or meibomian gland dropout. However, there are also other theories out there with some evidence that it might actually go the other way, that through a chronic inflammatory process, or through the fact that this muscle of Ryland that has to contract around the gland is not innervated appropriately. It does not have the functioning to innervate, such as a decrease in androgen causes an increase in inflammation, which causes those the innervation to the muscle to decrease, and the muscle doesn't contract, and that you actually end up with atrophy first. And then when it starts to atrophy, you then go the other way and get the keratinization and the decreased secretions out of the gland. So there's much work to be done and more understanding of how the meibomian glands actually work. And it may be a combination of both in different situations. Right. Associated risk factors with meibomian gland dysfunction could be things like anterior blepharitis, the scurf, and the Demodex that we talked about. And we're going to get into that in a little more detail as we go along. Another risk factor is contact lens wear. We know that people that wear contact lenses, within the first 2 years that they wear contact lenses, will have a significant amount of dropout or dysfunction of the meibomian gland. So there seems to be some type of inflammation that happens with contact lens wear that causes those dropout. Other things that we should look at when we work up our patients are things like androgens or hormonal therapies that are associated with certain conditions or aging that goes along. Antihistamines, we know, dry the eye out and can affect the meibomian gland. Antidepressants and glaucoma drops. Glaucoma drops are, in my practice, a significant factor. A lot of my patients wear contact lenses because of ocular disease, and those ocular diseases are associated with glaucoma and therefore glaucoma drugs. Retinoids, skin creams, anti-aging skin creams are very popular, at least here in the United States. And those anti-aging retinoid skin creams are actually associated with meibomian gland dropout as well. So systemic factors like menopause and aging or autoimmune diseases such as Sjogren's can also affect meibomian gland dropout. So there's a lot of comorbidities, maybe a chicken and the egg situation that you have going on with meibomian gland dropout, but we need to be aware when we see patients with MGD, we need to look for these other factors. When we see these factors, we need to look for MGD. So let's talk about how we evaluate and diagnose. We're really going to get into the weeds here and talk about clinically appropriate ways that we look and evaluate our patients and can manage this disease. So let the slit lamp. What do we see at the slit lamp? We want to have a lid margin, a healthy lid margin that's about 2 millimeters thick. It should be flat. It should be clear. When we start over time, chronic insult to the eyelid margin, you're going to start to see this rounding effect. It's going to be hard to see where the back and the front of it is. So we really measure it from this posterior mucosal line to the eyelashes, but it gets sort of round and thick. The other thing that happens over time with meibomian gland dysfunction is that the lid itself does not fully oppose the globe. And when you don't have good apposition, then it's like the windshield wiper on your car is not working appropriately. And so no, in a situation like this, no amount of just hot compresses or lid cleaning is going to restore the situation. When you don't have eyelid apposition, you need to start thinking about potentially a surgical a correction for this, whether it's to tighten a lid or to do a tarsorrhaphy or something to bring that lid back to the globe. The other thing you need to look for is telangiectasia, and that's those little blood vessels, the redness and the little blood vessels that are right along that flat eyelid margin. Telangiectasia is a sign of chronic and repeated inflammation on the surface of the eye. And this would be an increase in the cytokines, the interleukins, the tumor necrosis factors, the MMP9, all of those are elevated in people with chronic inflammatory situations. If you can control the inflammatory cytokines, you will then see resolution of that telangiectasia on the patient's eye. So this is a very key factor that should always be noted when the evaluation is happening. Very, very significant and acutely diagnostic of meibomian gland dysfunction. We do tend to see telangiectasia on the lower lid more than the upper lid. And the thought process there is because that's where the tears tend to pool, and therefore that is where you have more chronic insult of these inflammatory factors. We want to look for irregularities on the eyelid margin as well. So when you see a little dip in the eyelid, that is where you have had a previous insult to the meibomian gland, such as a hordeolum. And in these cases, you will see a corresponding dropout or atrophy of the meibomian gland behind there. So this is an indication that there has been a significant insult, such as a hordeolum infection of the eyelid. And you want to monitor that on patients, because when you see this, they are going to be more prone to more infections. That needs to be thought of when you're thinking about what is the patient's infection risk for procedures, for contact lenses, and for things you might be doing on the eye. You'll also want to look for any of these gross architectural or cicatricial changes on the surface of the eye as well. That may be indicating a chronic disease such as ocular cicatricial pemphigoid or some other type of chronic autoimmune disease. You're going to see these changes in Stevens-Johnson syndrome. You're going to see these changes in graft versus host disease. So these chronic horrible autoimmune diseases. Now, this mucocutaneous junction, this is very important that you know how to recognize this, because this, I think, is one of the most overlooked issues that we see with meibomian gland dysfunction. And the mucocutaneous junction is the junction between the mucous membrane and the keratinized portion of the eyelid. And the mucocutaneous junction is going to be, you see this little white line that you see right across there, and that is the mucocutaneous junction. Now, you want to see the meibomian gland orifices in the keratinized portion of the eyelid. When you have a slight entropion or turning in of the eyelid, this mucocutaneous junction gets pushed forward and then will encapsulate the meibomian gland opening. So you have the eye globe here. If the eyelid is turned in, you will push that mucocutaneous junction anterior. Now, no amount of hot compresses or lid hygiene or whatever your treatment of choice has been for your patients is going to change that anatomical difference. And so patients that are significantly bothered by dry eye, you need to look for that, because you may need to have lid surgery to pull that eyelid into a more reasonable position so that you you don't have that keratinized portion rubbing on the globe itself. So here's an example here where you can see the mucocutaneous junction here moved forward and starts to incorporate the meibomian glands here because you have that little microentropion. This is not a full-blown entropion where you end up with trichiasis. These are just little microentropions. And you can see this mucocutaneous junction here and the meibomian glands being incorporated into that mucocutaneous junction. Now you get at this mucocutaneous junction, you get something that's called ridging. Now ridging is where the keratin starts to build up. So you can see this is keratinized and this is the mucous membrane. This is the keratin on this lower one. You can see these little mounds of keratin. And this keratin can kind of build up at that junction and will actually cover the meibomian gland openings. And the meibomian glands will not function if you have these keratin ridges. So when you see ridging, you need to go in and scrape off all that keratin. And you can easily do that with a spud. You can do that with, there's several instruments that are out there that you can do it with. Even honestly, even a cotton swab and an algae brush can go in and remove that keratin off the eyelid. But those meibomian glands are not going to function, and you are going to have a symptomatic patient when you see ridging. It is difficult for patients to get all of this off themselves. It's very stiff. It's very difficult. Even if they wash their eyelids at home, they are seldom able to get that keratin off the eyelid. So it is something that you can do in-house, and I'll show you my process for how I do that. Now you need to record where the orifices are themselves. Ideally, you would like to have these beautifully round orifices spaced evenly apart on the eyelid margin there. Occasionally, you're going to see these doming, the capping or doming of the oil coming out of the glands. And in a normal eye, this is a very normal thing to happen. And patients will frequently say to you, oh, I just take my fingernail. I see it. I take my fingernail up there and scrape it off. They're very difficult to remove. You can't just wipe it off with a Q-tip. You do need to scrape this off because there is epithelium that forms over their top. Now, having one or two of these on the eye doesn't seem to be a problem, but if you start seeing it over most of the glands, you really do need to start with a more aggressive eyelid hygiene regimen on those patients. Now, pouting or plugging is different than doming. So when you have a dome, you can see the clear meibum that's below it. When you start to pout, the meibum has just inherently changed and has plugged up these glands, and the glands will start to sort of poof out a little bit, and they look very sore. They frequently are in this area of telangiectasia. And again, you need to go in and scrape these off and remove all the extra keratin that's around and constricting these glands, because eventually, if they're plugged up, it is going to lead to atrophy of the gland and the duct. And once you have atrophy of a gland or duct, there is no coming back from that. Those glands don't come back over time. So you want to prevent the death of the gland if you absolutely can. Now, you do need to note that if the opening is very narrow or is obliterated altogether, no amount of lid hygiene, hot compresses, or anything is actually going to bring those back. Some people do a procedure called a mask-in probing, where they stick a little probe in to dilate the gland. Some people report great results with that. Other people say that it damages the opening itself and will create scar tissue and is of little value. I have had patients that have had it done and not have it done. And some say they swear by it and some say they don't. So I think it's still out on whether you should dilate those openings with the mask-in probe or not. It does hurt and it does take quite a long time to do it. So it's a very expensive procedure to have done. Now, when you flip the lids upper or lower and you see these concretions, a concretion is a lime salt that's located in the acini itself. And everything downstream from those concretions is obstructed and eventually will die. Chalazion is this lipogranuloma. You can see the chalazion here and in the infrared picture here. They're more frequently under the upper lid than the lower lid, but they certainly can show up absolutely anywhere. You can see in this picture that once you have a chalazion, the meibomian glands generally are dead, dying, or atrophy in that area. So the glands that are involved will die once they get an infection like that. You don't want to look for the secretions. So you want to actually press on the gland while you're sitting at the slit lamp and see how many glands will secrete into the meibum and what's the quality of the meibum that is coming out of those glands. Frequently, you push on it and then the whole surface of the eye becomes very cloudy because the quality of the meibum is not very good. You want to count the number of glands and you just take your thumb and push how many glands secrete at once. If you have more than 4, that's perfectly normal. And if you have 1 or less, that's pretty reduced. You want to note the secretion quality of the gland. So is it clear or does it come out just a little bit cloudy? Or does it come out granular? So does it have that particles, can you see little particles in it, but it's still flowing? And of course, the worst is this inspissated gland here, where it actually has that toothpaste-like or the pudding-like secretions that come out of the gland. You want to measure a breakup time on the eye. So anything that's greater than 14 seconds is very good. Anything that's less than 7 seconds is going to result in an unstable tear film or more likely to lead to symptoms of dry eye. We often use tear film stability as an indicator for improved ocular surface stability in and of itself. So it's a good measurement to measure at first, and then over time continue to measure that tear film breakup stability. Now there's 2 ways to do meibography. So you want to look at the meibomian glands and say, are they there? Are they present? Are they blunted? Are there issues with them? And so you can use a meibographer, an infrared meibographer, and this is a fantastic way if you have a high-tech practice to be able to clinically document the actual presence or absence or the structure of the meibomian glands themselves. But it is not necessary. You can actually just take a flashlight. Here I have my transilluminator and just flip the eyelid over the transilluminator. And you want to look to see if they're big and thick and inspissated like they are here in the left-hand picture. Do you have dropout? Like here in the right-hand picture, where you have little tiny nubbins, right? They're little blunted glands. These are non-functional glands there. So you can just use a good old flashlight, basically a transilluminator, to take a look at these glands. You want to note if there's any tortuosity. Now, the jury's still out on what tortuosity means. Some people say that some research shows that people who have more evidence of allergic conjunctivitis have more tortuosity of their meibomian glands, and there's other evidence that this is just anatomical, and we really need to be looking at whether the glands are inspissated or whether the glands have atrophy as a more clinically applicable indication. When we think about this upper versus the lower, as I mentioned earlier, we really don't know which has a greater impact on the ocular surface. So there are some studies out there. It is harder to flip the upper eyelid. So there are some studies out there that say just flipping that lower eyelid is just fine. You don't have to look at the upper ones. And there are some studies that say, no, you have to look at that upper one because that indicates more tear film stability than the lower one. I look at both. Meibomian gland loss, once you start having, again, I mentioned you have to have about 1/3 of your meibomian glands in order to have a functional ocular surface. So about 1/3 need to be functioning at any given time. And so you want to know any areas where you do have meibomian gland loss, because again, no amount of scrubbing or hot compresses or pushing on those meibomian glands is going to help if you are in a state of significant atrophy. There's really almost no point in doing those hot compresses. I have had many patients referred to me who seemingly are doing hot compresses all day long and are having no improvement, and it's because they have no glands. Here's an example of some atrophy here where you can see where the gland was, but the gland is starting to drop out. And again, when the gland has atrophy, there's no functionality to it. There's many scales out there that you can look at that rate them on a scale of 1 to 10 or 1 to 4 or 1 to 10. I just tend to know where the dropout is and then discuss it with my patient appropriately. Now, if you want to get images, what you want to do is you want to have it all in a flat plane, right? You don't want to have areas where there's a lot of reflections. You don't want the eyelid not fully covered. Again, if you want to do this with a transilluminator, you can flip the transilluminator and then just use your phone if you have an iPhone or an Android phone. But you want to keep your fingers out of the way and you want to keep it all in the same plane. I now tend to take a lot of photography and just put it in the patient's electronic chart because a picture is 1,000 words. And you can have these, I've mentioned, we talked about these hordeum or these chalazion that can actually be in the gland itself. And this is where the next part of my talk is going to segue to is this idea of infection on the surface. About, oh gosh, 70% of patients that have chalazion hordeolum have also been documented to have concomitant Demodex onto the surface of their eye. Brevis, there's two types of Demodex. Brevis, which tends to be located in the Meibomian glands, and follicularum, which tends to be located in the eyelashes themselves. So if you have somebody with Meibomian gland dysfunction, with recurrent hordeola, you need to really evaluate them for Demodex and then treat the Demodex as well. So we're going to go into that here. Okay, this little guy's hanging out on an eyelash here. This is an egg, and this is a big bubble here, and this is a little egg that's on the eyelash here. You can see him moving and squirming. And you don't actually have to have a microscope in order to look for Demodex, in order to see the Demodex. You can certainly see that at the slit lamp or sometimes just, with your camera on your phone. I like using my microscope on occasion where I feel like I need to convince the patient that this is what they have going on and they've got these little critters, growing on their eyelashes. Patients become very compliant with their treatment once they see the little Demodex themselves. So what is Demodex? A Demodex is an 8-legged mite that lives in the hair follicle or in the Meibomian gland itself. Now there's lots of different versions of Demodex, but only 2 species actually live on the patient. So one of the most common questions that I get from my patients is they will say, well, my dog sleeps on my head. Am I going to get Demodex from my dog? And the answer is no. You will not get Demodex from your dog. You will not get Demodex from your cat. The Demodex is actually particular to humans. Now, you can give your Demodex to your partner, but you're not going to get it from your pet. You can be spread through towels, dust, pillowcases. The Demodex eat the skin and the hormones and the oils that are on your skin and in the hair follicles and in the glands. And it is a major cause, if not the cause, and it's more and more evidence showing that it is the cause of rosacea on the skin, seborrheic dermatitis, and other skin conditions. So we need to think about and treat those other skin conditions as well as the eyes. What I have experienced in my practice is that the dermatologists do not want to treat the ocular symptoms of rosacea. And so I have built very good relationships with the other doctors around me at my hospital and in the community, where they will send patients to me when they diagnose them with rosacea. They will send the patient to me to treat their eyes. So it's a very nice way to build your practice, to bring patients into your practice, is to be working with other subspecialties. So this little guy on the left here is a brevis, and this little guy on the right is a follicularum. The brevis is very short, and the follicularum is much longer. Where brevis is maybe 0.2, 0.3 millimeters, whereas the follicularum is 0.7, 0.8 millimeters long. You definitely can see these little guys at the slit lamp. They have about a 2 to 3 week lifespan, right? So what they do is they're born as an egg. They hatch and create this. They hatch and create the Demodex, but the Demodex don't have any way to defecate or to secrete. So they will grow and they will eventually just explode into the hair follicle. And then you will have decaying Demodex bodies in the hair follicle, and they get pushed out. And that's what the collarettes and the crud that you see on people's eyelids is actually the decaying and dead Demodex bodies. These dead bodies have a very important role on the surface of the eye, because it actually plugs up the hair follicle shaft so that things that kill Demodex do not get into the hair follicle, so that it creates this cyclical lifespan of the Demodex. In many studies now, it shows that about 25% of people aged 25 and 100% of people aged 70 have Demodex. So this is like a barnacle. As you sail through life, your boat collects barnacles. As you go through life, we collect Demodex. Our bioburden on our bodies, our bioload all over us, our skin, our face, everywhere, we have an increased bioburden as we get older. And Demodex happens to be one of those things. Demodex in and of itself, when you have a few Demodex here or there, not a problem. It's that increased bioburden that actually ends up being the problem for our patients. So we have to keep the bioburden down on the ocular surface, on the eyelids, in order to create good ocular health. If we have that increased bioburden, we have an increase of inflammatory products. When we have the increase in inflammatory products, we have the dropout of the Meibomian glands, the telangiectasia, and the changes to the conformity of the eyelids themselves. So Demodex, these are those little collarettes that I was talking about, and that's what we typically call anterior blepharitis. What happens is the skin, even if somebody's very good at washing their eyelids and at home and you don't see these collarettes, it does not mean that they don't have Demodex. Other things that you should look for are these little volcano-like skin where at the base of the eyelid, they have skin which is pushed up around the hair follicle. And those it's almost like a little volcano around the hair follicle that is pushed up because you have a clump of Demodex in there. You can also get these little folliculitis or infections that are on the around the eyelash itself. In posterior, signs of Demodex and posterior blepharitis is this pouting MGD, and also the telangiectasia on the lid margin. Patients with Demodex have an increased dry eye score on the ocular surface dry eye index, will have a normal Schirmer's with mite infestation. And about 85% of patients will actually have an increase in their evaporative dry eye, probably because that Demodex, that Meibomian gland component that's associated with the Demodex. You have a bad unstable tear film, you have an increased evaporative dry eye. Demodex is often confused with allergy, and that's because you do get these papillary changes that you see on the tarsal plate itself. There's a lot of itching. The patient will come in and say, oh, my eyes just itch. And so just by symptoms, a lot of times patients are just treated for ocular allergies, and it doesn't actually help. when the patients say that they itch, ask them specifically, when do you itch? So the Demodex actually come out at night. They don't like the light, and they're more likely to be active in the evening or at nighttime when it's dark. And these Demodex will crawl out of the gland and try to find a little mate on its eyelid surface to increase its diversity. And so the patients will frequently say, I itch more at night. Ask them to show you how they itch. And these patients will frequently pull down their eyelids and show you that they scratch at their eyelashes. And that is indicative of actually a Demodex infestation. Demodex is associated with other diseases such as Salzmann's nodular degeneration or stem cell failure in ocular rosacea. So when you start seeing patients that have this stem cell failure here, you really want to think, I wonder if they do have Demodex, and treat them for the Demodex. It can also be associated when you start seeing these staph marginal ulcers. Go back and think, does that patient have Demodex? And prove to yourself that they don't. Don't just treat that staph marginal ulcer. Remember that the Demodex themselves is just one of the flora, one of the bioburdens that's on the surface of the eye. But when you start getting increased bioburden, all the other bioburdens are going to increase, your staph and all the other bacteria that are on the surface of the eye itself. They all produce inflammatory products. A staph marginal ulcer is not actually an infection in the cornea. It is a cluster of white blood cells that are fighting the toxic effects of the secretions from the bioburden that's on the surface of the eye. Now, symptoms of Demodex is going to be, as we mentioned, the dryness, the blurred vision because the tear film's unstable, the irritation, the foreign body sensation, glare, crusting. And the strange thing about Demodex is once you start looking for it, you're going to be blown away that you feel like everybody has Demodex. And that's because a lot of patients just live with it. They think that's just the way it has to be, and they don't complain about it. It's just the way life is, and they consider it to be normal. They consider their itching and their irritation and their chronic annoyance almost like white noise in the background. They just tune it out and they don't think about it. A lot of these patients have had other treatments to little or no success. Dropping out of contact lens wear, they've had a lot of oral medications that they've taken, lid hygienes, steroids. The interesting thing about steroids is it decreases the inflammation on the surface of their eye, so it makes you more comfortable, but steroids can actually increase the mite count on the surface of the eye. So you get more mites and you can't get off of the steroids. And whenever they stop, they get very uncomfortable. But there's downside extreme effects, right? Glaucoma, cataracts, thinning of the tissues, thinning of the periocular tissue. Okay. So how do mites cause symptoms? So here's really the interesting thing. Demodex is actually colonized by a bacteria. So in the gut of the Demodex is a bacteria that's exclusive to the Demodex. It's not part of your biome, it's part of the Demodex biome. And when the Demodex die and they explode, not only do they have that release their dead little Demodex bodies that cause the inflammation, but the bacteria itself that is in the Demodex will actually cause inflammation on the eye. Interestingly enough, studies have shown that the bacteria that lives on the Demodex is most sensitive to the tetracyclines, to doxycycline, which probably explains to some extent why doxycycline is so effective for treating Meibomian gland dysfunction. Okay. The more mites you have, the more symptomatic you're going to be. And as I mentioned before, the interleukins, these inflammatory products that are on the surface of the eye, increase when you have these Demodex things. So let's just talk about how to look for Demodex. So you want to identify eyelashes that have scurf on them or that volcano-like eruption of the skin. You want to find what appears to be the sickest looking eyelash, the meekest looking eyelash, the one that it just doesn't look very healthy. And then you want to use your forceps and get right close to the base of the eyelash and stir it like you were stirring a batch of cookies, right? If you had a big thick batch of cookies and you're stirring it up, you want to stir it round and around, not pull it out. You don't want to pull it straight out. You just want to get at the base and you want to stir it around. And what that does is the follicle, you see these little lines right here, right at the base of the eyelash. Sorry, it's going in and out of focus. These little lines right here, those are all the Demodex being pushed out of the gland. And they will almost come out like a hand of bananas coming out like that, coming out of the gland. You can see all these little Demodex coming out. You don't actually have to pull one out. You can see this quite well at the slit lamp. Sometimes you just see them hanging on the eyelashes themselves. So you can see those little Demodex coming out right here. Now, if you are going to pull an eyelash, the eyelash is only there as a way of lifting some of those Demodex out so that you can put it on a microscope if you want to do that. And here I just pulled one of the Demodex off of the patient's eyelash. It's right here on the end of my forceps, and it'll come into focus here in a second. And you can see this is this little Demodex here. Now Demodex hate the light, so it certainly hates my slit lamp light. And you can see here in a second here how it's just kind of growing. It's trying to get away from me. This little Demodex is trying to, here we go. It's hard to keep it all in focus when you're at the slit lamp, but there we go. You can see this Demodex is trying to grow right there. Do you see it trying to get away from me? So you can see it quite clearly at the slit lamp when you're there. So stir it like that batch of cookies and watch those Demodex just come right out of that gland. It may be the major cause of contact lens dropout as people get older because of that dry component, but we certainly are needing more studies. So you cannot eradicate Demodex off of somebody. You can't eradicate somebody's biofilm or bioburden that they have on it. So you do need to be careful of how you talk to patients, because if you show somebody a mite, some people who are a little more mentally unstable about such things will go to great ends to get rid of their Demodex. So it's very important that you show them the Demodex, you show them that you have to keep it under control, but then somehow normalize it to the patient so that if they have OCD or some mental state where they just think they're crawling with bugs, it does not lead to a great ending. Heat kills Demodex, so you need to get it up to about 120 degrees. I don't know, Fahrenheit, I don't know what that is in Celsius, to kill the Demodex. So I tell people to take your bedding, put it at least once a week, put it into the dryer to get it up to that 120 degrees for about 20 or 30 minutes so that it can kill anything that's living in the pillows, or to use protective sheets to cover the pillow so it doesn't get into the pillow itself. Certainly scrubbing off the debris is very helpful. Doing any sort of oil or compress beforehand will help soften it so that you can get that debris off. I tell people it's like getting your fingernails done. If you soak, you can soak it in water, or you can put cuticle oil on it, but you still need to get that dead skin cells off of there. Baby shampoo is something that has been used or recommended for a very long time. That is no longer recommended because baby shampoo is very bad for the surface of the eye. I actually am now telling my patients to do dry hot compresses with, there are several ways you can do that. You can buy things that you plug in that are infrared that heat up just the eyelid. You can have bags where you put sand or rice or beans into a bag or a sock, tie it off, put it in the microwave and put that onto the surface of the eye. I don't recommend doing water hot compresses because the water actually increases the evaporation off of your skin. So if you've ever taken a nice long hot shower and you get out of that shower, your skin is going to tend to be more dry because you've removed the oils off of your skin. So you're increasing the evaporation off your skin. So when you do moist hot compresses, it actually dries out the skin around the eye, and the patients will say they're getting itchy or they're getting flaky or they're uncomfortable. They will stop doing it. So do high. What I do is oil and then a dry hot compress and then wash to scrub the eyelid margins off. And I'm going to show you what I recommend to scrub with. Tea tree oil will kill the mites. Manuka honey will kill the mites. Other things that have been proposed, like colloidal silver or other essential oils, are not effective and don't play a role in killing Demodex on the surface of the eye. And hypochlorous acid, I'm a huge fan of hypochlorous acid. I recommend it all the time. It does not seem to kill mites, but is very good at keeping the other bacteria, viruses, and things under control. When you have a significant facial rosacea itself, that this placoid rosacea is associated with Demodex itself. If you do a scraping on the surface of the eye, you will see the Demodex, just like if you were to pull it out of a hair follicle. The ivermectin is an antiparasitic. It can either be taken orally or it can be used as a cream on the surface of the eye. It's used very frequently for pets. It is more difficult to find for humans, at least in the United States, but we can even get it on Amazon for pets, but that's cream that can go onto the surface of the skin. You don't want to use that on the eye. I use oral ivermectin in patients that have a significant face and ocular Demodex situation. Other things that you can use for the skin would be permethrin cream or Urax cream. I tend to either use the ivermectin cream or the permethrin cream, but I do not use those on the eyes themselves. You do not want to use baby shampoo on the eye, as I had mentioned before, because it's quite damaging. And the reality is it doesn't actually affect the bacterial colonization on the eyelids itself. So baby shampoo is out. You don't use baby shampoo. As I mentioned with the hot compresses, you need to get in order to melt the meibum, to get that flowing, you need it to be at least 113 degrees Fahrenheit. For 4 to 6 minutes. I tend to tell patients to keep it on their eye for 10 to 15 minutes. The problem with heat, and what you have to be careful of, and I tend to use here the infrared masks, and that's because it doesn't actually put any weight onto the surface of the eye. When you use something like sand or rice that's heavy and you put that on the eye, the cornea is actually temperature sensitive. So when you put that sand or rice on the eye, it actually will deform the cornea. When the patient takes that off, they're going to say, oh my gosh, I'm so blurry, I can't see anything. And that's because they actually have deformed corneas that take a while to pop back. And I want you to understand my population of patients. I have a very high population of patients that have keratoconus or have had corneal transplants or have other ocular surface disease. And so the last thing I want to do is put something hot and heavy on their corneas that's going to deform their cornea and maybe potentially drive or exacerbate their disease. Because keep in mind, this is something we're going to be asking them to do every single day. So I like the infrared heat. If you're not going to use infrared heat, I like to use those little, they're called little hottie hand warmers, but they're like the little hand warmers that you shake up and you put into your mittens so that your fingers don't get cold. Or you can use the microwave things, just make sure they're not heavy on the eye. There's also gel ones that you can put in a cup of hot water that you can put onto your eyes. So there's many products out there specifically for heating up the ocular surface. This is a joke. You don't want to Dremel or use your power tools on somebody's ocular surface, but there are a number of instruments that you can use to actually just physically debride or remove the Demodex and the keratin, those ridge keratin, right, off of the surface of the eye. So again, you can stick a Q-tip in an algae brush. There's a number of products out there that you can specifically buy, or you can use a spud to scrape off of the surface of the eye, but they do need to be mechanically removed, any scurf and any keratin that's on the eye. I tend to use a lot of cleansing oils on the surface of the eye instead of water. And I do this because it actually nourishes the skin. It prevents that evaporation. So it protects the skin while softening the keratin and the Demodex. The one that I tend to use the most out there, a lot of people use sunflower oil or jojoba oil or castor oil. The one that I tend to use the most is coconut oil because it's so inexpensive and it's so easy for the patients to get. And a lot of people already have it in their home that they use for other purposes, whether it's for moisturizing their skin or for cooking, for makeup remover. So it's something that's pretty common to get. Coconut oil is a polar oil. Inherently, many of these oils inherently are actually antibacterial and antifungal. So the oil itself has some properties to help reduce the bioburden on the skin, and it tends to be an antioxidant and lowers the lipid peroxide levels on the eye. Peroxides are what we use that's what's excreted to damage the skin and things like that. So we want to lower those levels, and it's just calming to the skin. Clinically, what I have found is that patients don't hate using it because it makes their eyes feel calm or comfortable. It's like putting the fire out when they do it. It removes those collarettes, removes inflammation. And so therefore, if they don't hate doing it, it has better long-term compliance. I tell them to take a little of the coconut oil, put it on their eye, or whatever oil they use, but put it on their eyelids, brush their teeth, get into their pajamas, get ready for bed, whatever their routine is, and then come back with a dry cloth and scrub at those eyelashes to help just consistently remove any Demodex or any scurf that may be on the surface of the eye. Here's an example of a patient who had some significant Demodex collarettes on the surface of her eye, and then just with a month of home cleaning using just the coconut oil, she was able to reduce that bioburden and was much more comfortable just after, and that's just by scrubbing with the coconut oil. The other thing that you want to look at, though, is her telangiectasia, and you can really see that reduction in the inflammation and the telangiectasia on the surface of her eye. So she was much more comfortable, but this also indicates with the reduction of the scurf, but it also indicates that she had a reduction of the inflammatory process and her eye was able to heal. Tea tree oil, I will frequently have patients use just a little bit of tea tree oil, 5 to 15% in their coconut oil when they do those scrubs. Tea tree oil also kills the Demodex on the surface of the eye. It's antimicrobial in general, anti-protozoal, anti-inflammatory, and antiviral. So tea tree oil will kill anything that's on the ocular surface. However, it's very toxic to your ocular surface. You have to be very, very careful. There are some reports out there saying that you can use a 50% oil tea tree oil combination to do lid scrubs in office. I don't do that anymore. I use a 25% just because to do in-office scrubbing, just because that tea tree oil is so very toxic. But this is a very inexpensive way, a very inexpensive way for patients to get their Demodex under control at home. There's a number of products that are available on the internet or on Amazon that are a combination of tea tree oil and coconut oil that the patients can commercially buy to use at home as well. Claridex is the only in the United States FDA approved combination scrub, and this is actually just using a very specific component of the tea tree oil. This stings and it's very, very expensive. So I tend to use this when I have a patient who really wants things that are more controlled, patients who want to only use FDA approved products as opposed to creating their own coconut oil tea tree oil combination at home. Honey is incredibly effective for reducing bioburden, and specifically Manuka or Canuka honey, very, very, very effective. And it's interesting because the higher the concentration of the honey of the methylglyoxal in the honey does not necessarily mean that it is more effective. So you can actually get away with a UMF 10 or 15. The United States numbers would be equivalent to that would be around 400, but you can actually get away. You don't want the 20 or the 25 or the 30, because all you're going to do is increase the burning or the irritation on the eye without actually increasing the efficacy of the product. There also have been studies out there that have shown that the honey, the methylglycol, the actual component of the honey, that is more effective with the sugar in the honey than if they were to separate the methylglycol component alone. So the honey in and of itself, which makes sense, the honey is there to protect the beehive from fungus, from viruses, from bacteria, things that would eat the hive. And so it makes sense that the honey is actually effective on our skin as well. And so you want to look from a 10 or a 15. What I have the patients do is just take a tiny bit of that honey, and I mean an ever so tiny bit of that honey, and you can mix it with a little coconut oil so it spreads a little bit better, and just put it right on those eyelashes, right where the Demodex is in those hair follicles, and go to bed. I have them do it for a week, every night for a week, and then I have them pulse 2 or 3 times a week, and that's their forever habit. But it really keeps that under control. You will see the telangiectasia clear right up, and it's really quite remarkable. Patients I've been doing this for many years now, and patients will tell me, oh, it got better, so I quit doing it. And as soon as I start itching again, I remember that you told me to do this, and I put the honey back on. Now, honey doesn't really have an expiration date, and one little jar of honey will actually is like a lifetime supply of what you need on the eyelids. If it burns, or you've probably used a little too much, you need an ever so small amount of honey, really like the tip of a pencil, like about that much honey on the surface of the eyelids. Other things that people have proposed would be betadine. Betadine is very good. We use for reducing flora. We use betadine for our patients that have had artificial corneas, for example, the Boston K-Pros. We irrigate their fornices out to make sure that we've reduced all of that bioburden that could be on the ocular surface. The thing about betadine is that it hurts. I mean, it really, really hurts. So the other thing that you might want to consider for a lid cleansing agent would be hypochlorous acid. Now, there's 2 different versions. There's 0.01 and 0.02%. What you need to know about those 2 different versions is 0.01% is pure hypochlorous acid. Now, hypochlorous acid is what our white blood cells would release into a wound, right? So hypochlorous acid is naturally made by our body. It is a peroxide. And so it kills, it breaks down the cell membranes, the cell walls of the irritating or the pathogen that we wish to kill. So it kills everything that is not a human cell. Our cells have a barrier to the hypochlorous acid. So hypochlorous acid kills everything that's not human, but it will kill bacteria and fungus. It does not seem to have a big effect on Demodex itself. But you even in the age of COVID now, you're going to see a lot of hypochlorous acid cleaners for spraying down the house because it's not toxic, not like bleach or some of the other products out there that we clean our house with. Hypochlorous acid is non-toxic to us. So I use a lot of hypochlorous acid in my practice. When you see it at 0.02%, 0.02% is not the pure form of it. So it's going to have bleach byproducts in it, and you will get an increase in a dermatitis on the skin if you're using 0.02% compared to if you use the 0.01%. It doesn't just mean that there's more hypochlorous acid in the product. It means that for the same efficacy, they have to have more in it because there's other bleach byproducts that are in, it's not pure. Okay. Now, what I have done in my practice, and this is just something interesting that you might want to think about for your practice, if you're looking for an inexpensive and easy revenue stream into your practice, it turns out that patients really, really hate cleaning their own eyelashes at home, specifically if they have had, a corneal transplant or they have something else going on or they're disabled. It also turns out that a lot of our older patients like the contact. They like having a place to go. They like the hug that my technician gives them at the end of the treatment. They like having that social interaction. So I actually have created a dry eye spa within my practice. And in my dry eye spa, I simply clean people's eyelids. It's very inexpensive. I have a technician do it. I don't have to be involved with it, but patients just simply come into the practice and get their eyelids cleaned off. And then, of course, that brings them into the practice. It's a reason for other doctors to refer patients, as I mentioned, dermatology, but also oculoplastics. My cornea doctors refer in. My doctors who do cataract surgery, a group of doctors, they refer the patient to us to get their eyelids all cleaned off before cataract surgery, because we know that you have better outcomes for cataract surgery if you don't have that increased bioburden on your eyelids. It's a little bit like, you go to the dentist and get the plaque off your teeth. You can brush your teeth all you want at home, but you're not going to get all that plaque off your teeth. It's the same thing with the dry eye spa. When we were in lockdown for COVID, the only patients that were calling me, begging me to come into the hospital to see them were my patients that were in the dry eye spa. They were like, I'm miserable. My eyes are so miserable. I need my appointment. And so I have frequently patients, they come once a month and just get a treatment on their eyelids. It's kind of the same as if you got a massage or getting your nails done. And I price it in right about at what my market will bear for those other sort of aesthetic things that patients will frequently get, and that my patients pay out of pocket for it, and absolutely love it. So what I do is I put the tea tree oil combination, and this is my infrared mask. They sit there for about 15 minutes. My technician does a little massage on their temples and their eyelids and have a little chat with them. Then my technician goes in and cleans off their eyelids. This is another heating probe that I use for the eyelids. And then if necessary, we squeeze out. So if they're inspissated, right, they've got the thick meibum, then we squeeze that meibum out. Not everybody gets this treatment. Okay. Some people only get these treatments if they just have Demodex, if they're not inspissated. When we do express, we have several ways that we express here. This is just a little heated massaging wand that you can see the oil coming out of the gland right there. And we just run it along the eyelid, and the oil just comes squirting out of the Meibomian glands. So then I send them home with at-home care. I send them home with cleansing oils, some type of disinfectant, whether it's a tea tree oil or the honey or hypochlorous acid. I have them, do a lid scrub with the oil, heating masks, and then artificial tears with oil. I don't have an intense pulse light therapy in my practice, but it is quite effective in Meibomian gland dysfunction and in treating the Demodex on the surface of the eye. It's very, very expensive. And so I do have somebody that I refer to when I feel like the patient does need that. You're looking at tens of thousands of dollars for a unit, but that is also another way of setting yourself apart to get an intense pulse light therapy in, to be a referral center for people who want to treat that. But honestly, simple and easy, just setting up a little spa to clean people's eyelashes. I can run the spa all day long, every day, and actually have taken something that I hate more than anything in the world, which is telling people how to clean their eyelids in the clinic, but yet necessary. I refer everybody to my spa, and the person in the spa cleans their eyelids, tells them how to do it, and they pay her out of pocket. So I've taken something that I hate to do, and I've actually turned it into a revenue stream into my practice. It pays for the technician and so much more. So just in summary, to just go over everything, you want to look at the lashes, look for Demodex, look at the eyelid margin. Telangiectasia is that key sign, whether you have those inflammatory products in there. Make sure you're always looking for that ridging and that hyperkeratinization. Make sure you can get that off of the eyelid. If you have plugging, capping, or pouting, make sure you clean off that keratinization so that you can get that flowing. always look for the secretions and what that secretion looks like. If it's inspissated, you need to evacuate those glands. Look for the meibography, right? You want to look for if you have a dropout or atrophy, or even if your gland is connected to the eyelid orifice itself, because remember, no amount of hot compresses or anything is going to help once you have that dropout, although you can keep the bioburden off of the eye. And then anybody that has an associated risk factor, you want to tell them that they have an associated risk factor for this. And of course, send everyone to your spa, right? So I am going to conclude our talk there today and open it up for questions.
Okay, thank you so much, Dr. Christine, for such a wonderful session. Okay, now we are to move to our discussion session. Are you ready to take the questions, Doctor?
Yes.
Okay, I will be reading out the questions for you. Okay, our first question goes as, how effective would be intense pulse light therapy for treatment of MGD, and how does this therapy works?
So it is quite effective for that. And really what it does, one of the leading thoughts of how intense pulse light therapy does is it increases or decreases the bioburden on it, and can increase, and therefore increasing the flow. It decreases the inflammation, and therefore increases the flow out of the Meibomian glands and kills the Demodex and other critters that are living on the surface of the eyelids. It's very effective. It's very effective. And there's more and more evidence all the time about how effective it is. I just haven't gotten I haven't gotten my hospital to pull the trigger on the unit itself because of the price.
Okay, doctor, our another question is, what would be your suggestion to an adult with symptomatic MGD?
So if somebody has symptomatic MGD, I want to assess it to make sure I know specifically why or where I think that MGD is coming from, and their associated risk factors for that, because you may need to modify those associated risk factors if possible. I will in-house clean their eyelids off, and then take the time at that moment to explain to them what's going on. I will look for Demodex and things like that as well. And then I will send them home with the regimen that I outlined at the end of my talk there. The big thing is just to keep those eyelids clean, scrape all that stuff off.
Okay, doctor, we have another question. Which will affect more to Meibomian gland, either irregular Mark's line or anterior-retro displacement of Mark's line, or it depends upon their severity?
It is if you have that anterior displacement where it's rotated forward, those are not functioning at all. So you really need to look at the anatomy. Can it be fixed, or are you just going to have to live with it, right? But once you start to see structural changes, it's much more difficult to manage that patient. So if you can pick up on these changes before you start having those structural changes, that's really where the biggest impact can happen.
Okay, doctor, we have another question. What are the things that should be ruled out in cases of chronic or recurrent MGD?
What needs to be ruled out?
In cases, yeah. Do you hear the question?
It's really, you need to look at it, like in addition to the MGD, you need to, like, what else could it be besides MGD? If I'm reading into that question, one of the things is you have to make sure that it's actually MGD and not something like a squamous cell carcinoma. And so I've certainly seen cases that have been sent in to me where somebody's had a chronic chalazion or chronic irritation in that area, and it has been treated as MGD, and it actually turned out to be a squamous cell carcinoma. So we have to remember that there are other eyelid diseases or eyelid lesions, chronic inflammatory situations that do need to be ruled out as well. in some cases, you have sort of a chicken and the egg situation where, you have MGD, but you also have another underlying cicatrizing disease. So, for example, I have seen patients which were treated for chronic blepharitis or chronic MGD that actually had an underlying disease like ocular pemphigoid or a Sjogren's disease, which will actually start causing some of those anatomical changes to the eyelid margin, which are thought to be MGD, but are actually an underlying disease that needs to be treated as well. So you need to keep a full, I had that list up there of associated conditions. You need to keep that associated list in your mind when you're seeing MGD.
Okay, doctor. We have another question. Does MGD can also cause short TBUD type of dry eye?
Well, MGD is dry eye. I mean, it's all associated, right? So dry eye is a pretty generic term or generic word. So anything that's irritating to the ocular surface could be considered dry eye. MGD is a component of dry eye. So when you think about dry eye in general, you really think about the layers of the tear film, right? So you've got the mucus, the proteins, if you will, that are on that first layer that prevents the water from drying up like water on a waxed car. Then you have the tear film component, and then you have the oil component on the top, right? So MGD is really affecting that oil layer that's on the top. But other diseases such as Sjogren's syndrome, age, many other diseases that affect the lacrimal gland itself are going to decrease the amount of water that we actually make. Or you could have diseases that are actually of the surfaces themselves. So for example, Stevens-Johnson syndrome, or graft versus host disease, and a number of other diseases that actually affect that mucus production, the mucous membrane production. Those are all dry eye. So Meibomian gland disease is one level or one layer of a whole dry eye package that somebody may have.
Okay, doctor, we have another question. Which is the gold standard questionnaire for evaluation of dry eye? OSDI or SPEED?
Oh gosh, well, that is a question that goes back and forth. I think either one is fine. For studies that I do, I can go back and forth. It really depends on what when I'm doing a group study. I would say the SPEED questionnaire is what a lot of people use clinically. The ocular dry surface index is probably what I use more for studies.
Okay, doctor. Our another question goes as, how effective is LipiView in determining average lipid layer thickness in cases like Stevens-Johnson syndrome or conjunctivitis?
Okay, say that again. How effective is what?
LipiView.
The LipiView. So I don't have a LipiView. I have a keratograph. I love it. I take images all the time with it. I would have to say I use it more for education of patients. Any of the infrared cameras are fine, but there's Meibox. There's a bunch of them out there now. If you want to have an infrared camera, so the various different price points with that. Great for patient education. Great for following patients over time. As far as Stevens-Johnson and graft versus host and conditions like that, I probably find it less effective for those conditions. And the reason why is because the natural course of those diseases is going to lead to fibrotic changes of the lids, right? So no matter what we do, I cannot change the course of that disease. So over time, the mucous membranes are going to become fibrotic. The lid is going to become fibrotic. The meibomian glands are going to die and drop out. So it doesn't do me a lot of good. I mean, I can watch them do that, but there's nothing I can do to change that. So I probably use it less in those conditions than I would say in somebody who we maybe have factors that can be changed.
Okay, thank you for your answers, doctor. And also thanks to all attendees for coming up with their questions and for making this discussion session more interactive. Okay, we will be
Great.
waiting for a few more minutes if anyone is willing to ask, and then we will end the discussion session. Okay, we could not get any questions till now. Okay, considering the time limits, here I announce the closure of discussion session. And I would again like to express my immense gratitude towards Dr. Christine for such a wonderful presentation and to all the attendees for their endurance. I would also like to thank all the direct and indirect helping hands for the iTalks program. Before wrap up, I request our today's presenter, Dr. Christine, to share her few words to our program.
Thank you for having me.
It's our pleasure to have you with us, ma'am. We will love to see you again, even in the future.
Yeah, love to be here.
Herewith, I announce the closure of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you.